Okay, hello everyone. Hello to the Covidsurg network and hello to all of our viewers and collaborators who have tuned in, and thank you very much for your time. What we'll be doing today is a 1-hour webinar to launch the results from our Covidsurg Cancer paper. So this is about the results of elective surgery performed during the first wave of the pandemic. We'll show you these results. We really want your questions and your feedback, so start thinking about them. We have got a diverse and global panel here today who will both be presenting and providing an expert commentary. And it's a pleasure to introduce them. So I'll go in the order in which you'll be hearing from people. So I'll start with James. Hello, James.
Hi, Anil. Hi, everybody. Thank you very much for joining us. I'm James. I'm a general surgery registrar working in the West Midlands and a research fellow in global surgery, and I've been part of the team leading the Covidsurg Cancer project. I'm delighted to be here with you today.
Thank you, James. And I'll introduce Anna next. So Anna, it's a pleasure to hear from you.
Hello, everyone. Thank you for joining us. Thank you for the opportunity to be here. I am a colorectal surgeon working in Henares Hospital in Madrid, Spain.
Thank you. And Kay from a lovely sunny day in Hong Kong.
Hi, Anil. Hi, everyone. Thank you for letting me join you. I trained in Birmingham with Anil, and I'm currently working as a colorectal surgeon in Hong Kong.
And last but not least, the most handsome man I know is my old friend Wale from Nigeria.
Hi, Anil, and hi, everyone. My name is Wale Adisa. I'm a general surgeon working in Nigeria, specifically in Elective in the southwest of Nigeria. It's been a very pleasurable ride working with Covidsurg, and particularly on this Covidsurg collaborative. Thank you for having me.
And Wale and I overlap into the global surgery world. He has delivered hundreds, if not by now thousands of patients randomized into the Falcon and Cheetah trials. But we'll save those results for another day. Okay, so we'll start with some slides and hopefully you can see that. So really, this is a presentation of the data that most of you watching will have contributed to. And thank you very much, because it's this real data that we can learn how to use to bring benefit to our patients. These are our range of funders, and the funders really came forward very quickly and very collaboratively, and we're very happy to work with each other and work with us to launch this platform through which we could start collecting data within, it actually started within a week of the earlier shutdown in March that happened in the UK. So we are very grateful to all of these funders, and they're listed there. So to talk about the network, this has become a huge network. We can link together thousands of surgeons across literally thousands of hospitals in over 100 countries, and there are very few networks that can do that front line. So we're good at building networks, as all of us are, across Europe, across the broader world, but this one has come together faster than any, and it just goes to show the level of effect that the pandemic has had. So although we're presenting the JCO paper today, it's worth noting that we've got over 50,000 patients into the Covidsurg database, and we will be looking to release those results as quickly as we can. We are trying to do it with a certain quality, so we're trying to go quickly, but we are trying to make sure that the final thing that is published, you can take it to your managers, to your teams, to your anaesthetist, and use it at that stage with the knowledge that it's not going to change because it's been reliably analysed. And a note of reflection, so in the start of the pandemic, we did a modeling exercise and we identified that about 28 million elective cancer surgeries were cancelled in the first 12 weeks of disruption. In most places, that disruption is ongoing. And we recently estimated that the number of elective operations cancelled is probably now in excess of 100 million. So the impact on our patients is huge. We are facing second waves and lockdowns. We're beginning to lock down in my area. Our hospital is now reducing elective surgery again. So our data is timely. And although we will be presenting it in a way that says, this is good data, go off and do it, we're going to be realistic as we go to the panelists and we ask about how we're actually going to use this data. And this data, you'll have seen, it is hitting the media. This is a mainstream topic. People having cancelled elective operations is really important. And it's one of the only topics in surgery that cuts across every single specialty, from orthopedics to head and neck surgery. And we've had a paper on head and neck surgery from this collaborative published in the journal, accepted in the journal Cancer in the last week. So this is a truly cross-cutting topic. And we're going to link this to the Lancet paper. So the Lancet paper we published showed a huge mortality and morbidity from patients who underwent surgery and had a perioperative diagnosis of SARS-CoV-2. The question that came back to us is that these rates are too high and we're not seeing those rates. But actually, if you look at that group of patients, you will see those rates. But we'll show you how that data fits with the wider denominator across your hospitals in this paper. On that note, I'm going to pass over to James, who's going to start the first half of the presentation, and then we'll ask a quick question to him and to the audience, and then I'll go over to Anna. So James, you'll take control of the screen. Are you ready?
All sorted. Thanks, Anil. So thank you very much. So I'm going to talk to you a little bit about COVID-19 free surgical pathways, how they were defined in our recent Journal of Clinical Oncology paper, and congratulations to all of the network for publication in such a high impact journal, one of the leading cancer journals around the world. And I'll talk to you a little bit about the evidence of its effectiveness. And then Anna's going to talk to us about where and when COVID-19 free surgical pathways should be applied and for what groups. So firstly, what were COVID-19 free surgical pathways? Well, people around the world call these different things. People call them cold centers, COVID light centers, green centers, but effectively they are hospitals which have complete segregation of all areas where the patient is cared for, away from patients being treated for COVID-19. And in this study, we define those as being the operating theatre, critical care, and inpatient ward. And COVID-19 free surgical pathways could be present as an independent hospital that was only delivering elective cancer surgery with complete COVID-19 free surgical pathways, or they could also be in the major acute hospitals with emergency departments, for example, where there was complete segregation of that pathway. Everything else, where there is any mixing of patients, potentially or definitely with patients with COVID-19, were defined as hospitals with no defined pathway. So we had two different groups that we were comparing in this study. And our question really was, these efforts that people have been making around the world, these major, expensive, challenging efforts to protect patients from the risk of SARS-CoV-2 infection in the perioperative setting, have they been working? Have they been manifesting as a reduction in the post-operative pulmonary complication rates compared to hospitals which have not defined a COVID-free pathway? And as many of you will be aware, as people that have taken part in the study, this was the method that we used. We included patients that had been operated in a planned elective setting for a curable cancer type. And those patients had to not be suspected of SARS-CoV-2 or COVID-19 in the perioperative setting. So patients with a symptoms or a positive swab would be excluded from this study, unlike in the Lancet paper. And we collaborated across 10 different surgical oncology disciplines, including gynecology, colorectal surgery, intracranial tumors, head and neck. This was a really broad study which looked at all patients undergoing cancer surgery during that early phase of the pandemic. We started whenever locally the first cases of COVID-19 emerged in the community around the hospital, and we ended inclusion on the 19th of April, 2020. This is a nice graphical representation of those COVID-19 free surgical pathways. So in green, there was areas with no mixing of patients with those treated for COVID-19. And in orange, there was a risk of patients being mixed with patients with COVID-19. So in order to be defined as that COVID-free surgical pathway, all of those areas, the ward, the theatre, and the critical care had to be have no mixing with COVID-19 patients. Anything else for the hospital with no defined pathway. It was a labour of love to get the different definition correct. Our primary outcome measure for the study was the same one that we used to define pulmonary complications within the Lancet paper. And that included pneumonia, acute respiratory distress syndrome, and unplanned ventilation, being failure to extubate at the end of an operation or unplanned ventilation within 30 days after surgery. And this matches definitions used, for example, within the PRISM trial, which was a major multi-center randomized trial. Now to the results, the exciting part. So in this early part of the pandemic, we included over 9,000 patients from 55 countries having operations all around the world. And in a majority of countries, there was centers present which had both COVID-19 free surgical pathways and no defined pathways. So this was not a phenomenon which was just in specific countries, for example. Now, in terms of the case mix, so the patients that underwent surgery in hospitals with and without a COVID-19 free surgical pathway, there was a slight tendency for case selection for lower risk patients to be operated in COVID-19 free surgical pathways. However, there were similar proportions of major cancer surgery that was done in COVID-19 free pathways and those hospitals without these pathways, and all types of operation, those done for esophagogastric cancer and big sarcoma operations, HPV surgery, were done in both COVID-free pathways and hospitals with no defined pathway. We looked a bit at preoperative testing in this paper, and we won't focus on it to a huge degree, but I think it's an important part of the story. And so interestingly, in this early phase of the pandemic, just 1 in 5 patients were getting a definitive preoperative test. And at that time, that was being either a swab test or a CT scan, although we know evidence developing now suggests that there's limited effectiveness of a CT scan alone. Of those 20% of patients, a majority of those were done with a swab test. And there was a higher rate of testing in hospitals that define themselves as having this COVID-19 free pathway than hospitals without, but it was far from incomplete within the early part of this pathway. And these were the outcomes that we saw across those 9,000 patients. So in hospitals with no defined pathway, there was a higher rate of SARS-CoV-2 infection and subsequently a higher rate of pulmonary complications and death seen in those hospitals versus hospitals where the COVID-free pathway had about half the risk than that seen in those with no defined pathway. And you might say, is this just related to that difference in case mix that we saw earlier? And I'll explain to you briefly now what we did to try and compensate for that difference in case mix and demonstrate that we think it was due to differences in the risk of SARS-CoV-2 infection rather than anything else. And the first thing we did is quite a complex statistical technique called Bayesian mixed effects modeling. And what that does is adjust for patient, operation, and disease-related factors that were measured within the study in terms of attributing the odds of getting a pulmonary complication. And what we saw after adjusting for all of those factors was that there was a consistent and independent link between having surgery in a COVID-19 free surgical pathway and having surgery in a hospital with no defined pathway. So this clear benefit despite differences in case mix. And to go a bit further to make sure that this difference we were seeing again wasn't due to selection bias, we did propensity score matching, which is sort of a pseudo randomization where you match patients based on specific characteristics. And there was still this consistent benefit. We took out all the patients that had a high baseline risk. So we looked at those with an American Society of Anesthesiology grade 1 or 2 only. And again, there was this consistent risk and benefit to cold pathways. And finally, we looked at patients that had a definitive test preoperatively to prove that they were SARS-CoV-2 negative. And there was still this benefit seen again of those COVID-19 free surgical pathways. So what we think that shows is there is definitely this benefit to redesigning services to prevent mixing with COVID-19 patients. And it's probably not due to just the differences in testing alone, because when we took patients that had a proven negative test preoperatively, there is still this benefit seen. So take-home message from part 1, COVID-19 free hospitals were those with that policy of no mixing of patients, and it did seem to improve outcomes in those COVID-free pathways, despite differences in case mix. Thank you very much. I'll go back to Anil for the questions.
Thank you, James. So I'm going to ask a question to Kay, but also a question should pop up on your screen because we'd like to get your feedback as well. So Kay, my question is, can we take these results and begin to implement surgical pathways in our centres, bearing in mind that every single hospital is different? Have you managed it? Have you started to do it?
Yeah, so I think it's great to have paper, some evidence behind this wish, because we all know logically that if you can avoid exposing our patients to COVID, then hopefully the risk will be lower. But of course, to make these changes requires a lot of changes and a lot of money and manpower. And without evidence, it's very difficult to do that. So luckily or unluckily, Hong Kong, we had SARS in 2003. So unfortunately, we've already had this pandemic experience. Actually was based in the hospital I'm working at. So they had the first patient was admitted to this hospital, and within days it had spread through the hospital, affecting patients and staff, and staff taking it back to their own home and infecting their families, and many patients, families of doctors and nurses died. So as a result, when this pandemic broke out in end of January in Hong Kong, they were very quick to act and try and make every hospital COVID-free as soon as possible. So we had no visitors allowed to any public hospitals from end of January, and that still holds. We try and isolate all COVID positive patients into hospital, and they do contact tracing to try and minimize spread. For surgery, now that they're testing methods more readily available, we do test all patients before coming in for any surgical or endoscopic procedures to try and minimize the risk of bringing asymptomatic patients with COVID into hospital.
Quick follow-up question, Kay. Did you get these pathways, is it clinician-led, or do you have to use the data and engage your managers, for example?
I think they are all working as a team. I think it has definitely helped that they had the experience of SARS, so they haven't needed to wait for evidence to come out for COVID specifically to make these implementations. But I think it will, the evidence will definitely help to streamline and fine-tune the COVID-free centres for elective surgery.
So the results of the first poll have just popped up, the early results. So about half of people have started or have a COVID-free pathway. 20% of people have begun. but still a third of people have a mixed hospital setting. Now, another quick follow-up question to Wale. So Wale, in the UK, we were caught slightly short, and we did not have COVID-free pathways, and they've taken time to set up, and they're still not complete. What's been the experience in IFE?
Yeah, thank you, Anil. What happened was that initially the surgeries were virtually shut down completely, but to restart elective surgery, what happened here in IFE was that everybody knew that we don't have the capacity to manage COVID positive patients undergoing surgery, especially because of the results that were coming out at that time regarding the complications, particularly the pulmonary complications. And so in restarting elective surgery, the hospital decided to start sorting out patients based on their COVID status, and to ensure that there's a form of a pathway where patients are not mixed together. And this study, this latest publication has come at the most appropriate time to just reinforce the fact that that was a very good decision made by the hospital at the time. So patients are screened at the two entry points, the accident and emergency, as well as the outpatient surgical clinics. And each patient undergoes some form of screening there. And any patient that is either suspicious or proven to be positive undergoes further screening before they are decided upon. But no COVID positive patient is admitted on the surgical ward or taken to the main operating theater where elective cases are done, or to the intensive care units. So I think we've been able to achieve that free pathway.
Thank you very much, Wale. So let's move into the second presentation. So it will be over to Anna. So Anna, can you take control of the screen?
Okay. As it has been said before, we found that COVID-free surgical pathway provided benefit to our patients. But the next question is, under what circumstance should we implement them? For this, we studied the effect of COVID-19 free surgical pathways in different settings. Regarding incidence, high versus low community incidence, type of patients, low and high risk, and also the component of the pathways. So we classified hospital as being in communities with low and high SARS-CoV-2 incidence. We considered hospital with high incidence when more than 25 cases per 100,000 population, and low incidence when less than 25 cases. And we found that pulmonary complication rate were lower in patients treated in COVID-19 free surgical pathway in both low and high in low and high community SARS-CoV-2 risk areas. However, the benefits was higher even in areas with high incidence. In conclusion, the benefit was observed in areas with high and low incidence, but in areas with high incidence, the benefit was even higher. We also studied the patient risk. We found that male, gender, older age, and patients with cardiorespiratory comorbidity presented higher risk of pulmonary complications. But when these patients were treated in COVID-19 free surgical pathways, the pulmonary complication rate was lower than when treated in non-defined pathways. So patients with high risk and that still need a surgery could benefit of these COVID-free areas. We also analyzed the pathway components. And we found that complete COVID-19 free surgical pathways and critical work were associated with a lower pulmonary complication. This is quite important for those large hospitals that need to treat patients with COVID-19 and still have to continue with major surgical activities. To summarize the benefit of COVID-19 free areas, high and low incidence, and we have a group of patients with there is also a dose response effect. This means that the effect size increase in proportion with the number of the components of the pathway. This is very important for large hospital. And from our data and this paper justified the major service redesign, obviously based on local resource. Thank you so much.
Thank you very much, Anna, and well done. So I've got a couple of technical questions about the data, which I'll come to in a moment. They're going to be for James. But I would like to start with this question again for the panelists and as a poll about what are the major barriers in setting up these pathways. So I'll ask myself first, one of the major barriers we have is around staff and around testing of staff, around having a complete anaesthetic team when critical care is getting very busy, about having a complete theatre team when there is the combination of sickness and redeployment. And I do accept that this data can't directly address that, but the way I will be using this data to address the staffing issues is that there needs to be a pathway for COVID-free environments, but that pathway is not foolproof unless there is a pathway for the staff as well. So the way I will be using this is to be looking at the physical environment, but also the staffing environment. And I will be looking for robustness in anaesthetic teams and in theatre teams to ensure that we can set up wards and theatres and critical care, but we can also staff them. So I see one of the key issues around staff, but I'll be interested to hear what everyone else thinks as well. So could we start with Wale? Wale, what are the barriers in your environment to setting up the perfect system? Have we still got Wale, or has you there?
Yes,
you are.
I'm here. I'm here. Neil, can you hear me?
I can hear you.
Okay, great. With us here, the challenges are a lot more about the cost of setting it up, as well as the logistics of running this pathway. For instance, if patients are supposed to be tested in our own setting, and I think this represents what obtains in many of the low and middle-income countries, the cost of the testing is borne by the patients, and therefore bringing additional cost to the patients. And if the patient cannot afford that, there are also hospitals where they don't have a PCR machine and the patient has to travel somewhere else to go for this testing and then come back to the hospital where the elective surgery is to be done. Again, I've heard of laboratories here running out of testing kits. I've heard of personnel not being available enough for the number of patients sent for testing for elective surgeries in a day. So there are quite a number of issues that constitute barriers to effectively running this pathway in our own setting here.
That's very interesting. And I'll ask the same question to Anna. So Anna, in Spain, what are your barriers to getting these pathways up and running?
Well, the main barrier, I think, that is when you don't have the resource enough, and this happens in the wave when you are in the peak. But once we pass the peak, I think the main barrier was the logistic and to have the methodology of screening. You need to coordinate of the health worker. You need to inform every worker about the new organization. At first, nobody know where to do the things, how to perform the normal procedures. But once it is over, I think it is easy to follow the rules. So mainly the resource at the first to have the possibility of screening. This is very important to start. I think that is very important, the work with all the team, all the equipment and the policy of the hospital. It is also very, very important that the hospital directors, managers understand the importance of achieve this result in implementing COVID-free areas.
Thank you, Anna. Now, I would like to just drill down back. We've got the poll results. So interestingly, staffing and workforce is a big problem. Logistics are a big problem. And as Wale commented, costs are also an issue. Very few people, 4% of people face no barriers. So this is clearly a global issue. Now, Lizzie, who is just in the background, I'd like to go back to one of the slides, please. So that's the one. That's the first slide. I just want to drill down. James, I'm going to ask you two questions in the technicalities of the data. So when I look at this slide, what I see is there are factors about age, about gender, and about ASA, which is really a measure of comorbidity. And risk seems to increase with those, but there's nothing about the operation or the size of the operation. So how do I interpret that information?
And thank you very much, Neil. So these were the three key determinants that we found within the models. And I think, as we saw in the Lancet paper previously as well, actually the patient level factors seem to be more of a determinant to the risk, the outcome, than some other factors. But if you remember, there was quite a disparate range of operations included within this study. So for example, this included both thoracic operations, esophagogastric operations, and those done for head and neck cancer and breast cancer. So for esophagogastric surgery, naturally the rate of pulmonary complications was much higher because of the risk of thoracic contamination than in breast surgery, where this rate was much lower. But what we did see was that there was this consistent benefit despite any differences in case mix within the hospitals.
So as my next wave hits and I have to choose patients due to capacity constraints, because that's the reality, what just tell me if I'm right in my thinking. If I'm doing a major operation in an older man who's ASA 3 versus, and it's a difficult discussion, versus a younger woman who's having a day case mastectomy, I'm not going to ask you to pick between those patients. I'm just being careful. But would it be reasonable to start prioritizing patients based on their risk? Is that what the data begins to enable us to do?
Yeah, in some ways. I think there's two things to think about, really. There's firstly the baseline risk that would have been apparent in the pre-pandemic period. So, for example, an esophagogastric patient would always have had a higher risk of pulmonary complications with or without the COVID pandemic happening. And what we've shown here is that in a cold setting, in a COVID-19 free setting, there is minimal additional risk from SARS-CoV-2. But the other thing to think about is the ITU use and the collateral impact on other services. So from our data, you can see that in breast cancer surgery, day case surgery, minor operations, there was this lower risk of pulmonary complications, regardless of whether it was in a hospital with a free pathway or hospital with no defined pathway. So if you're thinking about the overall, the absolute risk of complications, then the data here may help with your case selection.
So bearing in mind, I said, I'll just make a statement of how I could interpret this. So if every hospital is different, if I'm put in the position where there's no critical care beds, where the hospital's really busy with COVID, the A&E's overrun, but you know, we have got an operating list, I would probably pick a lower risk, younger patient, get them in and out quickly. If I have to do a bigger operation in an older patient, let's say someone who is fit, but is in an older male, and they need a big operation. What I'm taking from this data as a whole is that they're best served by being in a COVID-free pathway, and the patient probably needs to understand their risks. So that's how I'd be looking to use that data. Now, Lizzie, can I take control of the slides? I just want to go back to, there's one more bit of data that I just want to, thank you very much. I just want to see if I can, at the risk of saying next slide, I'm just going to try and go back. So James, I'm just going to pick on you again, just to nail this down. Some of these rates look quite low to me. So if I was to say with no COVID-free pathway, 5%, 6% pulmonary complication rates might be acceptable. So can you just nail down on those bits where it says no pathway, and just explain to me why those rates are not optimum?
Of course. So if you remember, we included a wide range of procedures, including minor operations and those for breast cancer and intracranial tumours, where there is a low rate of pulmonary complications at baseline. So the rate that we might see in esophagogastric surgery, hepatobiliary surgery, colorectal surgery, thoracic surgery was obviously much higher than that. So the overall rate perhaps has drifted downwards as a result of that comparison. I think one of the important things to say here is that this study was completely consistent with the data published in The Lancet about the impact of SARS-CoV-2 on pulmonary complications. What we have here is the absolute denominator, so the number of patients that did suffer an infection was actually quite low, as we saw in a previous slide, around 2% in COVID-free pathways and about 4% in hospitals with no defined pathway. But for patients that did contract an infection, they had that same 50% rate of pulmonary complications and a 40% risk of death that we saw in the Lancet data.
Thank you very much, James. So if we can get back to the speaker view, that'll be great. But I've got a question for Kay. It's a tough one, and she's not expecting it. So let's say I've set up my hospital and we've got a COVID-free elective pathway. I think COVID-free emergency pathways are probably too difficult, so I won't comment too much on them. But as a surgeon, what do I do if I've got to do an elective operation, but I've also got emergency patients to look after? How are you coping with that in your environment?
So luckily, we have not had any general surgical patients with COVID as yet in our hospital. We've had 2 ENT patients needing tracheostomy, but that's the only patients with COVID positive requiring surgery so far. Answering your question, we aim for hot and cold teams. So I think it's also the case in UK, in some other units, where if you can try and minimize crossover of staff looking after COVID positive patients and negative patients, I think the risk to the patient, in addition to the rooms and the theatre complex and ITU setting, I think will be of benefit. So if you can sort out the manpower to have a cold team looking after your elective patients and a hot team looking after your emergency patients, it will be ideal.
And Wale, same question to you, and then we'll go to Anna. So Wale, how do you deal with you needing to see elective and emergency patients?
Okay, thank you, Anil. So here, we don't have the luxury of having personnel for hot and cold. And it's the same team that sees the emergency that sees. So, but what we do is, in emergency, a very full PPE is used in assessing patients in accidents and emergency. The testing is done, and if a patient is positive, then those patients are put in the isolation ward that was newly constructed in the hospital. And if the patient requires operation, in most instances, that operation is done in the OR in the emergency, where no elective cases are done. So in this, at this very moment, the patient testing positive to COVID do not come to the theaters, the ORs, where elective cases are done, but we still have that switchable personnel, which we just heard, probably is not the best, but due to limitation of personnel, we just can't, for now, separate the teams.
Thank you, Wale. Anna, can I ask you the same question? How as a group of surgeons are you organising yourselves around elective and emergency care?
Well, we don't have different teams for COVID patients and non-COVID patients. We are not splitting in different teams. We are the same team. In emergency, we have two areas, one for patients with symptoms of COVID and other for patients that come for other reason. We performed screening with swab test to every patient before having emergency surgery. We in case that we don't have time to wait for the result of the test, we use PPE equipment. All the patients that go to elective surgery, of course, they have now a swab test before surgery.
Thank you very much. In our environment, we are lucky enough to have enough surgeons where we can have this concept of hot and cold teams, and we cover 2 sites with some redeployment to A&E stuff, to ITU built into those rosters as well. So could we put up the final of the audience quizzes, please, to get some audience feedback? And the question is, how will you use this in your daily practice? Because that's really what we're trying to gather the data toward. One question that I would ask, and I'll ask James again, to go back to James, is whether, if I'm a different type of surgeon, so if I'm an orthopedic surgeon, or if I'm thinking about bariatric surgery, or if I'm thinking whatever it is, do you think, how cautious do I have to be about using this data? So to remind everyone, this is elective cancer surgery. So James, how cautious do I be in the other areas of my practice?
That's a really good question. And it all comes down to generalizability and how much we think this data about cancer patients can be shared to other disciplines. I think it's important to remember that during those early phases of the pandemic and during those first slides that you showed us all, the cancellation of surgery was largely in benign and non-cancer orthopedic surgery. So in order to capture any surgery at volume within this study, cancer was the obvious choice, because as much as possible we tried to protect our cancer patients by continuing surgery for them. So this was the evidence that was available from that time. And I do think when you're looking at other major surgeries, then there will be cross-relevance to your practice. For example, in Roux-en-Y bypass and bariatric surgery, you've got a similar approach and operation type to maybe esophagogastrectomy in some senses. So I do think there is definite patterns within this data which will help planning across elective surgery and not just within surgical oncology.
Thank you very much, James. I'll begin to wrap up this session because we've just got a few closing comments. As a final question, just for everyone, again, we'll start with Wale, then we'll go to Kay and Anna. None of us know what the future's going to look like at the moment, and we don't know if we're seeing second waves, third waves, what 2021, 2022 is going to be like. So here we are facing a definite second wave, and we're beginning to lock down. And we are trying our best within all the limits of ITU capacity and the wider surgical team to adhere to surgical-free pathways. When should we begin planning for the future? Do we need to get through winter and see, or should we be using this data to plan and engage teams now?
Anil, thank you very much. That's a very good question, because for us here, with the first lockdown, it was very difficult for surgery because everybody was wondering what exactly to do. And now with this evidence that we have, we can begin to have guidelines in case there is another lockdown, in case there is another wave of the pandemic. Then we didn't know what to do, even with benign elective cases. I mean, I'm talking of something like acute cholecystitis, and everybody was wondering what exactly were we supposed to do. Like everywhere else, a lot of cancer cases were also canceled. But from this data we presented and shared today, we know that even if there's another wave, we have evidence in surgery to begin to plan and prepare, to also prioritize which patients we can safely operate upon. For us in low and middle income settings, it's not just the operation, but the possibility of complications, our ability to rescue patients when, for instance, a pulmonary complication occurs, and how many ventilators do we have? How many intensive care units do we have across the country? So from the results of this study, we can begin to safely formulate policies, even from now, that based on the age, the gender, the comorbidities, we can safely select patients that can safely be operated upon with minimal risk of complications that usually stress our own systems. So I think the time is now for us to formulate policies towards any possible second wave in the near future.
Thank you very much. And the same question to Kay. So Kay, you stated earlier, you highlighted that you were probably in a better position due to past experiences. So can the rest of the world learn from that?
I think the numbers been different. We've been quite lucky to keep the numbers quite low. Despite having the third wave, we're still able to contact trace and quarantine everyone to try and minimize spread. But I think one thing that, as Wally said, is that the evidence that you've given us has highlighted the high-risk patients, better patient selection if we need to operate, but also that COVID-free centers may allow us to continue operating even if there is a surge of COVID in the future. So if there's a second or third wave in the future, we might still be able to allocate a hospital to be COVID-free and continue operating so that we can continue to treat patients. Because one of the things that I have found in Hong Kong now is that there's so many patients who had symptoms, but they were too scared to come into hospital with fear of catching COVID, that they've actually turned up 6 months later with complications of the tumor that could have been avoided if they had presented to hospital earlier. So I think we should try and continue treating our patients in the safest environment possible so that we're not going to have a bottleneck later on.
Thank you. And Anna, same question for you. How is planning in your hospital in Spain? Are you planning for the immediacy? Are you planning for the future?
Well, we have now COVID-free areas. This will continue for a long time, I suppose. I think it is very important because with this, we are returning to normal surgical activities. I think that there is other point that these COVID-free areas also allow that patients with other diseases can also be attended in the hospital. In the future, I think we are going to continue so. Also, I think it's important to highlight that these COVID-free areas are very important when you have high incidence, but also when you have low incidence. So although you are not in a peak or in a wave, you can still benefit of it. And it is very important because also there are patients with high risk that still need a surgery, that maybe the surgery cannot be delayed forever. So you have to take a decision. On this sense, I think that this paper and this data are very helpful to make decisions and stratification risk patients.
That's very useful. Thank you very much. Okay, well, I'd like to thank all the speakers. Thanks, James, for leading on that paper and getting it out into the public domain, and to Anna for her presentation and leadership in Spain. And thank you to Kay and Wale for giving us ongoing support and commentary. And Lizzie, could I go to we'll just a couple more figures, then we'll do a wave goodbye. So a note about Surge Week. This is the chapter 2 of the Covidsurg story. So this is a study that is delivering the current state of play around the world in terms of the total number of operations done, what the previous SARS rate is, and what the current COVID rate is. So the story is that whereas the first paper, the Lancet paper, showed you the risk of the disease, so that's surgery with SARS-CoV-2. The second paper, this JCO paper, shows you the effects of doing an elective operation during a pandemic wave. The third paper shows you the broader denominator. So that's trying to capture every operation done in the hospital, and it will show you both the effects of past COVID and the current impact of COVID on that site. So if you haven't taken part, you've just got time to get data in by the end of this month. But actually, Dimitri, who's leading on this, is telling me that we've had over 10,000 patients submitted in just a few days. So this is going to be one of the world's biggest studies into every type of surgery done. And it's that generality of surgery which really gives us an international appeal. And the final thing I'll comment on is just a nod to what other data we're releasing next month, so in November. So as I've mentioned, a study on head and neck cancer will be coming out in the journal Cancer, which is a phenomenal piece of work and shows the rates in that group of patients. We've got a paper coming out in colorectal disease, the journal, and that will talk about what the stoma rate was and what the impact of anastomotic leaks were during that first phase of the pandemic. But one of the cross-cutting papers we've got coming out, which we will be planning another webinar for, will be around testing. So the British Journal of Surgery, the BJS, we're hoping to get online with them, and that is a a specific dedicated paper about what the minimum testing you have to do to get patients through their pathway safely, and also what the clinical impact of that testing is. And that's going to be another practice changing paper, because that's going to provide the evidence we need to say whether we need to do 1 swab, 2 swabs, CT scans. And as a hint, it looks like that's going to point toward doing a minimum number of swabs. So please keep an eye out for that in the British Journal of Surgery, and tune into our next webinar. This webinar will be available to watch again in YouTube and look at all those slides, and please do download the paper. So I'm going to wrap it up there, but thank you all very much, and thank you very much to the speakers as well. And thank you very much, and goodbye.